I know why. Unfortunately, RLR had to be canceled last minute. I was like, man, there's something heavy on my chest right now. I've missed this. And now I know why, live. We're thrilled to have everyone here. And before I pass the mic to Prof. Rez to say a quick hello, I'd love for you all to volunteer to present a case. Today is the one day where we don't share the stage with people from the chat, and instead Rez and I share our reflections in real time, but would love for somebody to present a case. So before Prof. Rez says hi, ooh, Rafa has a case. All right, okay, deal. Rez, please say hi and we'll jump into Rafa's case.
Hello, everyone. So excited to be here with Robbie John and the rest of you and the CP Solvers family. And if Rafa has a case, it's going to be an exciting hour. Very excited, Robbie.
I think we should start with some magic, maybe. So, Rafa, jump in and we'll have Reza share his thoughts.
Abracadabra.
I'm just gonna wait for Kiara to start sharing the screen. So, thank you. So this is a 56-year-old woman with type 2 diabetes, hyperlipidemia, and hypertension. And she presented to the ED with a 4-year history of productive cough and shortness of breath on exertion. And that's the end of aliquot number 1.
All right. And Rafa, did you say 4 years of
Yes.
productive cough? 4 years, right? Okay.
Mm-hmm.
And the reason I ask to clarify the timing, because timing is everything in clinical reasoning. One is tempo of disease, the other is sequence of events. I won't spend too much time in this aliquot, but we have 2 problems in the clinical syndrome. One is productive cough, another is dyspnea and dyspnea on exertion. So what I'm going to use as my center of gravity is actually the finding that actually has a broader DDX, being the dyspnea on exertion. Because cough is probably going to be related to what's driving the patient's shortness of breath. So with shortness of breath, all you have to do is go to Robbie's Twitter profile. He has a terrific pyramid for subacute dyspnea, and maybe someone can link that in our chat below so you guys can see the graphic representation. But ultimately the question becomes, is there pathology within the heart, the lungs, or other? Here, the fact that the patient has a productive cough makes the other category, like anemia, deconditioning, metabolic acidosis, thyrotoxicosis, chest wall deformities, neuromuscular disorders, less likely. Just from this one sentence, we have to prioritize the heart and the lung. And then there you can take an anatomical approach, whether it's the myocardium, endocardium, pericardium. And then within the lungs, if we are saying that this is leading to the shortness of breath and it's a productive cough, it tells you that there's probably alveolar pathology or filling of some substance, water, white blood cells, or other. The chronic nature is very important. And something else that's going to be very important is whether this patient's inflamed or not. I'm going to stop there. Looking forward to more information from Rafa, and looking forward to the mathematician discussing the next aliquot.
Okay, so the patient noticed an insidious development of dyspnea on exertion and cough for 4 years before, just like I told you guys. She also noticed pain and color changes on the fingers of both hands that were more bothersome during the winter or upon entering air-conditioned rooms. And the cough and shortness of breath gradually worsened. The patient also noticed the development of subcutaneous nodules on the elbows and dorsal aspect of the hands bilaterally. On the review of systems, it was negative for weight loss, fevers, joint pain, tenderness or swelling, morning stiffness, digital ulcers, skin rashes, or red painful eyes. This patient also denies any recent travel or sick contacts. Family history was unremarkable. This patient also denies history of smoking, alcohol, or drug use. And her home medications consisted of lisinopril, simvastatin, and metformin. And that's the end of aliquot number 2.
Alrighty, Rafa, this is a fantastic case, primarily because of the time course. It's unusual for patients to come 4 years after shortness of breath, but then there are a lot of extra thoracic complaints. Like the patient has, Reza was talking about heart or lung, and now we're talking about fingers and nodules. And most people with a cardiopulmonary disease process only have lung or heart findings. When you think about the number of times that people have skin or vascular phenomenon as part of their cardiopulmonary syndrome, it's very rare. Now, how do we know it's a vascular phenomenon? Whenever there's dynamic changes in color and pain, that highly supports a dynamic process, and that dynamic process is usually vasospasm. And what you're describing here is what sounds a lot like Raynaud's. With exposure to cold, vasospasm occurs, mainly in the winter, causing pain and color changes. And Raynaud's is a tricky syndrome because it comes in 2 varieties, primary and secondary Raynaud's. And primary is so much more common than secondary. And secondary refers to Raynaud's that's as a result of an identifiable disease process, such as an autoimmune condition like scleroderma or lupus or dermatomyositis, or a trigger that's from a cold-induced disease like cryoglobulinemia or cryofibrinogenemia, or even cold agglutinins can sometimes precipitate in the cold, cause ischemia, and then when the patient warms their hands, the cryos or the cold agglutinins dissolve. And so here the question is this patient have primary Raynaud's, which is very common, which is then unrelated to the current syndrome and has nothing to do with her cardiopulmonary complaints? Or do her cardiopulmonary complaints push us to consider the fact that she has secondary Raynaud's? And in general, there are some clues to help you prioritize primary versus secondary. The age of onset is 1. Most people with primary Raynaud's are young, usually younger than the age of 40. Most patients with primary Raynaud's are women. Most primary Raynaud's is mild in severity, not prolonged, meaning that the pain and color changes only last for 20 minutes or so, and does not result in any consequences to the digits. So there should be no ulcerations. And curiously enough, a fun fact, primary Raynaud's almost never involves the thumb. So here, the question is, are there red flags? And it's tricky. I think that the fact that there's a syndrome associated with it makes us wonder if it's secondary, but I'm open to the possibility that this Raynaud's is an innocent bystander to an otherwise wide disease process. And maybe I can pass it on to Prof. Rez to reflect, if it is secondary, how he might connect that to the cardiopulmonary syndrome that he was outlining. And then we can talk about the lung nodules, the elbow nodules at some point too.
Robbie, I love that. And it reminds me of the case that Aaron presented to you, I think like a year ago, of secondary Raynaud's, that the patient ended up having dermatomyositis. And that led to you creating this epic schema, which someone should share. Actually, I'm looking at it right now, and I'm going to put it in the chat so you guys can pull it up too, because I think it's very educational. But, I think the points you make, Robbie, the patient's age and the pulmonary findings, it's very difficult not to look at the DDX through linking these two together. The exam is going to be important, but what kind of rheumatologic diseases can cause pulmonary disease, Raynaud's, and subcutaneous nodules? I think right away, just through pattern recognition, one concern is systemic sclerosis. And most rheumatologic diseases come in middle age, and many of them may affect women more than men. So now I'm applying the epidemiology of the patient. So what's going to be next? Well, of course, we're going to listen to the lungs to see if we auscultate crackles. We'll look at the digits. We have to be cautious with interpreting the pulse ox, just given the findings of vasoconstriction. So we might have to do an earlobe to get an accurate assessment. But really for me, Robbie, what's going to be the branch point is going to be the labs. The serologic studies, including ANA, complements, the CBC, are going to be crucial in trying to identify what's happening. And when I said systemic sclerosis, what I'm thinking of specifically is CRESS syndrome, where you can get calcinosis, you could get Raynaud's, and of course, you can have the pulmonary manifestations of ILD. So where do we go from here? Well, we're going to do the exam. We're going to go to the labs. And with rheumatologic processes, I'm always open to like overlap of syndrome. So could this patient have RA, rheumatoid nodules, and Raynaud's? Very feasible. So I'll be using the list that we have on our schema and be reviewing the data based on that list. So very excited for the physical exam, Rafa.
Okay, so awesome discussion as always. I just forgot to mention that this is a case that originally published by Dr. Kervinside that I really loved. And so when it comes to the physical exam, this patient had a temperature of 37.6, 81 beats per minute. The blood pressure was 112/75. And this patient respiratory rate was 17, and her oxygen saturation was 92% on room air. The physical exam was remarkable for decreased air entry with bilateral final inspiratory crackles at the bases. The skin exam revealed multiple 1-2 centimeters firm, painless subcutaneous nodules located on the extensor surface of both elbows and over the right third proximal PIP joint, the left second PIP joint, and the left fourth PIP joint. The musculoskeletal exam revealed no joint abnormalities, and such there was no evidence of joint swelling, tenderness, effusion, deformities, or decreased range of motion. Anything else was just unremarkable. And that's the end of the autocot.
Awesome. Maybe I'll cover the vitals and the crackles and leave the nodules for Robbie to discuss. But right away, we were concerned for hypoxemia. We just want to make sure that this is an accurate pulse ox. Of course, Rafa is, I think, presenting a case from the Human Diagnosis Project. But if you're evaluating such a patient, you would want to check their earlobe somewhere where there isn't the concern for vasoconstriction. Currently, we're not seeing any findings of Raynaud's. It'd be very important to examine the skin to see if there is findings of scleroderma. And many times these patients look younger than their stated age because they don't wrinkle and their eyes are sort of prominent. So those are all things I would look for. And finally, you can take your ophthalmoscope, apply some gel to the fingernail and look to see if there's any capillary dilation, which again would be consistent with secondary Raynaud's, not primary. The crackles can mean something's in the alveoli. It could mean the alveoli are collapsed like atelectasis, or it could be interstitial lung disease. If we look at this through the frame of secondary Raynaud's, then ILD is prioritized in the patient's physical exam, but an X-ray will be really important because you could have rheumatologic conditions associated with vasculitis and also bleeding within the alveoli. I think that's far less likely based on the tempo of disease. That being said, Robbie, I don't really have like a DDX for nodules. Love to hear your thoughts and happy to help PRN.
You know, I'll try to take it as far as I can, although like it's more for me like association rather than a systematic approach. I love the point about the hypoxemia. I totally would have missed that. I think what's really helpful is the combination of nodules and the lack of synovitis. You know, because if you approach nodules in general, associated maybe with an autoimmune disease, if you apply that filter, the most common cause of nodules that I see are from gout, which is I think the best descriptive term of gout, where people come in screaming of pain and they have nodules. usually over the earlobes, but also over the hands. And here, the absence of joint disease makes gout much less likely. The other prominent autoimmune disease that causes joint issues and nodules is rheumatoid arthritis. And here, there's been many a patient who lacks frank synovitis and has evidence of arthritis on X-ray. But here, a very good joint exam without arthritis makes these unlikely to be rheumatoid nodules. Another much less common cause of joint disease and nodules is what's called multicentric reticulohistiocytosis, and it sounds really long and fancy, and which makes it sound really rare. It is rare, but it really has an incidence that's not that every patient with rheumatoid arthritis, the rheumatologist thinks about this diagnosis, and you'll see that in their notes before they diagnose the patient with rheumatoid arthritis. So those are the three joint plus nodules differential diagnosis, which again is gout, rheumatoid arthritis, and multicentric reticular histiocytosis. And those are much less likely because there's no evidence of frank synovitis on exam. But just like the lungs, sometimes you don't see anything or notice anything on exam of the lungs with your stethoscope and with your eyes, but you'll see something on X-ray. So here the question is there joint disease on X-ray that will help us prioritize between these three possibilities? There are two other prominent autoimmune diseases that can spare the joints and cause nodules in the form of calcinosis. So if these nodules are especially hard, that might pull you into them being calcinosis. And it's in the name for one of them. It's CREST, and the C stands for calcinosis. And calcinosis can occur in any part of systemic sclerosis, be it the limited version CREST or the disseminated version of systemic sclerosis. And the final autoimmune disease is dermatomyositis. Dermatomyositis can cause calcinosis. So I think that's what I'd be prioritizing. And the latter two, the ones that tend to involve the vasculature in the form of Raynaud's, dermatomyositis and scleroderma, are probably a little bit more likely at this point because they both spare the joints and tend to involve the vasculature more so than gout RA or multicentric reticular histiocytosis. So I think that's where I'd be at. And to link it to the lungs, I think Reza already said that the overlap between autoimmunity and lung disease is extensive. And I think both of those would be good fits for the lung issue. So I think the next step is to get the labs and get the imaging of the lungs to know exactly what we're dealing with. And I think at the end of the day, serology probably to look for those autoimmune diseases is going to be very helpful. This is one of those instances where the biopsy of actually on the skin, the biopsy of the nodule is not so helpful in general, and attention to serology is probably more productive. Anything to add, Prof. Rez?
Not my friend. That was awesome. Thank you, Ravi.
Okay, so the white blood count was 4.43. The RBC, the hemoglobin was 12.8. The platelets were 296. Sodium was 147, potassium 5.5, chloride 103, BUN 9, creatinine 0.8, calcium 10, total protein 7.9, and the albumin was 4.4, AST 20, ALT 11, alk-phos 61, total bilirubin 0.3, and glucose was 112. Just to give you just a little bit more information, other lab tests were significant for anti-citrulinated peptide antibodies, 29 being the normal from 0 to 20. Rheumatoid factor was positive with 61, being the normal from 0 to 13, and the ASR was 56. This patient also had normal or negative ANA, anti-double-stranded DNA, anti-JO antibodies, anti-MI antibodies, anti-topoisomerase antibodies, anti-SSA, and anti-SSB antibodies. All of those were negative or normal.
Awesome, super helpful, Rafa. Maybe I can talk about the ANA and then leave the rest for Reza to analyze. And You know, whenever you're thinking autoimmunity, you almost reflexively think ANA, and it's a very good test for many things. You'll hear conversations about ANA, and I think the best one, quite honestly, is a tutorial from Anne-Marie that you should all try to look up from Twitter. My biggest takeaway from that and other conversations about ANA is that the higher the titer, the more suggestive it is of true autoimmune disease. It is too sensitive, meaning that many people who have no disease can have a low titer positive ANA. And you'll see that that dominates the conversation about ANA. Here we have the exact opposite conversation to have. What does a negative ANA mean for autoimmune disease? More often, the conversation is, oh, shoot, patient has a positive ANA. What do I do with that? Here, it's, oh, shoot, the patient has a negative ANA. What do I do with that? And that's what you have to remember. This is actually a pretty helpful scenario for only two diseases. 95% of patients with lupus have a positive ANA. And so if your pretest probability of lupus is moderate or low, lupus is gone. And there's another disease that vanishes when you have a negative ANA if the pretest probability is moderate or low, and that's scleroderma. Because 90% of patients with scleroderma have a positive ANA. So here, the negative ANA makes lupus and scleroderma much less likely. Other autoimmune diseases can commonly have a negative ANA. Sjogren's has a negative ANA in 30% of patients. Rheumatoid arthritis, negative ANA in 50% of patients, about. And the same is true for all the myosidities. So here, the negative ANA is tremendously helpful because it makes lupus and scleroderma, which are two very common causes of secondary Raynaud's, much less likely. So take advantage of the negative ANA. If you're worried about autoimmune disease, you can put two of them virtually aside when the ANA is negative. All right, I'll pass it to you, Rez, for the rest.
Very, very helpful, Robbie John. So looking at the CBC, nothing too alarming. Here we're looking for markers of inflammation. The white count is normal, hemoglobin is normal, platelet count is normal. You look at this chemistry panel and you see that the K is a bit elevated, the sodium is a bit elevated, the creatinine is normal by lab standard, though we don't know what her muscle mass is. So you wonder if there's some degree of kidney injury, or are the labs lysed leading to a K of 5.5? I only say that because it's important that we think about hyperkalemia and the effects it can have on the myocardium. Otherwise, this disease does not seem to be involving the liver. And looking at the ESR, it just is a marker of inflammation, but there isn't too much going for active severe inflammation. So Robbie talked about the negative antibodies. Let's focus on the positive ones. In general, RF, when it's positive, you have to be very cautious to jump to the diagnosis of rheumatoid arthritis because it ends up being positive in many disease processes. For example, if someone has cryoglobulinemic vasculitis, their RF might be positive. Someone with CMV, infectious mononucleosis, might have a positive RF. So the RF you always take with a grain of salt, but just like any laboratory abnormality, you want to apply it to the context of your patient. So here, the CCP being positive and the RF being positive raises our concern for what? Rheumatoid arthritis. So now we apply the illness script of rheumatoid arthritis. Who does rheumatoid arthritis affect? Women more than men. This patient's a woman, it's about 3-to-1. Middle age, patient is middle age. Another risk factor is family history. So these findings may prompt me to ask the patient, do they have a family history of rheumatoid arthritis? Now, RA by definition is primarily an articular disease. And the way you can do that is just go from your wrist to your ankles, your hand to your feet, your elbow to your knee, your shoulder to your hip. Could this be RA? And this is where Robbie made a very important point. Just because we don't see evidence of active arthritis doesn't mean this patient didn't have arthritis. So this patient warrants hand films, without a doubt. Then you ask the question, could nodules be part of RA's illness script? It's one of the most common extra articular manifestations of RA, primarily in seropositive patients and in those who smoke, usually more so in men. But Robbie, where I am right now is that the 2 positive antibodies makes me think of RA. I think the nodules on the elbows can be an extra-articular manifestation. I think the lungs through ILD. So my leading hypothesis at this point is rheumatoid arthritis with extra-articular manifestations, which would fit the patient's epidemiology and time course of clinical syndrome. So where do I go from here? Hand films, and I would go straight to a CT scan of the chest. You can get an X-ray, but the X-ray, like I'm really concerned about ILD, and I would want to know if that is present or not. Robbie, anything to add before we get additional data?
Superb, my friend. I absolutely love them.
So now we have one more aliquot before the final diagnosis. So the pulmonary functional test showed a forced vital capacity 65% than expected, a forced expiratory volume of 70% than expected, and the FEV1 FEVC ratio of 89.7%. The CT chest showed bibasilar predominant diffuse ground glass opacities with volume loss and bronchiectasis without evidence of honeycombing by apical reticular opacities associated with arterial distortion and parallel thickening consistent with scarring, and no mediastinal lymphadenopathy. And I can actually share with you guys the CT scan if that's possible.
Rafa, can you share with us again so we can just take a look at it first? Maybe 30 seconds. And I guess you guys can see sort of these, I don't know who's, oh, Rafa, can you show sort of the ground class opacities and the bronchiectasis? Maybe you can put your, yeah, one of you, yeah.
It's
you can see
these
dilated
dilations,
airways.
right? Mm-hmm. The
Right.
dilated airways, right?
Exactly right, Rafa. Those dilated airways you guys can clearly see. And then down there at the bases, you can see sort of this sort of white stuff that's not clear, right? And they read it as ground glass opacities, Rafa, is that correct?
Yes, yes.
Excellent, excellent. Okay, very good. So since I just spoke for a long time, I'll just say, Robbie, I'm gonna pass the mic to you and then I can share my thoughts too.
You know, I don't have much to add. I think that this is that, well, one, if you're walking into the CT with the pretest probability that you're worried about rheumatoid arthritis because you have nodules and positive serologies, you have to step back and be like, well, how can RA affect the lungs? And the short answer is RA can do everything to the lungs. It can cause airways disease in the form of bronchiectasis or bronchiolitis. It can cause pulmonary disease, ILD, through NSIP, IPF-like disease, and actually in patients who are exposed to pneumoconioses like silica, that can cause a combination disease called Kaplan syndrome. RA can also affect the pleura and cause pleural restriction or effusion, but it tends to spare the vasculature. So pulmonary hypertension is less common with RA than it is with the other autoimmune disease. And so here you have findings compatible with it. You have findings of bronchiectasis and what looks like NSIP with basilar opacities. So here, I think the question that is lacking in this case, that pushes us to move from the accelerator to the brake is to say, well, why does the patient not have joint pain? And what would clinch the case for me is if we get x-rays and we see joint evidence of RA, and there are some pathognomonic x-ray findings. So the only reason pressing pause and asking what else can be fooling us and what else causes a false positive RF is the lack of joint symptoms, and that concern would be ameliorated with x-ray findings of joint disease. RA is also less commonly associated with Raynaud's, so that's another soft reason to put your foot on the brake. But at the end of the day, it is probably described, I've heard it, but I'm not sure, that rheumatoid arthritis, like all autoimmune disease, the illness script can be presented in the wrong order because patients don't read the illness scripts and sometimes may present with lung dominant disease. And this is true of some autoimmune diseases. They can write their story in reverse, which is why pulmonologists have to know RA very well. And so maybe this is the story of RA written in reverse, or maybe there's subclinical joint disease only detectable on x-ray, or maybe you should not listen to anything I said in the last 40 minutes because we're completely wrong. It's one of those three possibilities, I guarantee you. All right, Prof. Rez, to you, please.
I love it. I'm right there with you. And honestly, let's say this patient was in the hospital or in my clinic. At this point, I would be making a referral to a rheumatologist because I think the patient needs immunosuppression. But like Robbie said, oftentimes we associate this with an articular disease, though there's a lot of data right now that's pushing you towards rheumatoid arthritis. Yeah.
Okay, so the clinical presentation, the laboratory results and imaging findings were consistent with a diagnosis of connective tissue disease associated with ILD, a non-specific interstitial pneumonia subtype. And treatment options were discussed with the patient, and eventually mycophenolate mofetil was initiated after discharge. So there's this clinical pearls that the author made that I really enjoyed, that among the extra-articular manifestations of RA, the most frequently encountered are cardiovascular disease, cutaneous manifestations, including rheumatoid nodules, interstitial lung disease, vasculitis, ocular involvement, gastrointestinal, neurological, and nephropathy, and ILD are among the extra-articular manifestations of RA, and I want special attention since up to 10% of RA patients can develop a clinically significant ILD, and RA-ILD confers the patients a higher mortality rate in comparison to RA without ILD, likely due to the comorbid conditions including ischemic heart disease, congestive heart failure, and diabetes that affect this population. And the most common subtype of ILD in RA is the usual interstitial pneumonia, followed by the non-specific interstitial pneumonia subtype, which was this case. And cases of RA-related ILD presenting in patients without articular symptoms may pose a diagnostic challenge, delay treatment, and lead to unfavorable outcomes. So this is actually the exception that Ravi was talking about. The patient initially presented with pulmonary manifestations and later on with articular manifestations.
When Ravi was saying, thank you so much, Rafa, for the case and for the teaching, and whoever actually wrote this case, I think thanks to them too. When Ravi was saying that the patient is trying to write their story, Kushal, it made me think of Hamilton and the stories that Hamilton kept writing. In any case, thank you, Rafa. Let's pass the mic to our dear friend Kirtan to break down the teaching points. And I know Kushal is going to go watch Hamilton tonight since I mentioned it.
Yes. So thank you so much, Rafa, for presenting a rheumatology case, which is what I love. And thank you to Prof. Rez and Ravi for discussing it. I think they should not be called as internists. They should take the job as rheumatologists. They discuss it amazingly. So we started the story with productive cough, dyspnea, and Raynaud's. So Reza told us that what is the localization? The fact that patient has chronic productive cough, the dyspnea points somewhere to alveoli or the interstitial department of the lung. And then Rabi told us that what we make of vascular changes. Of course, there is Raynaud's, but we know there are primary Raynaud's and then we have secondary Raynaud's. So Rabi taught us that what are the pointers that can guide us towards the secondary Raynaud's rather than primary Raynaud's. So the fact that the symptoms are progressive, they are symptomatic, and it has been going on for 4 years. I mean, it's something too rare for primary nerves because sometimes it resolves on its own. So the fact that they are progressive since 4 years, they are chronic and systematic features are there. So we have shortness of breath, we have this cough, which makes us think that this is probably secondary Raynaud's rather than primary Raynaud's. Then comes the part of pattern recognition, that how we put all of these things together. So if we have vascular involvement, if we have pulmonary involvement, and if we have cutaneous nodules, then how to fit all of this together. So there are various ways in which we can put them together. So one of them is rheumatoid arthritis, which is classic to cause subcutaneous nodules. Then we have systemic sclerosis. Then we have mixed connective tissue disease, and finally overlap syndrome. So MCTD and overlap syndromes are kind of similar, but not actually similar, because MCTD involves overlap of systemic lupus erythematosus, systemic sclerosis, and either polymyositis or dermatomyositis. So if you have anything else outside of these 4 disorders, let's say if you have features of RA, if you have features of Sjogren's, then it won't fit into MCTD and it would fit into spectrum of overlap syndromes, which is a vaguely described entity. And of course, as the rest told us, that serologies, complement levels will guide us to narrow down the differentials. Then we talked about the nodules. So Rabi pointed out that what if nodules are not actually nodules and they are calcinosis cutis? And calcinosis cutis points us in another direction, because they are very common in dermatomyositis along with systemic sclerosis. So we have to think about systemic sclerosis along with dermatomyositis as possibly causing calcinosis cutis, which are masquerading as the nodules. And furthermore, there was no evidence of synovitis on examination, which is typical in rheumatoid arthritis, although atypical cases may occur. So lack of synovitis again raised the suspicion for systemic sclerosis more so than rheumatoid arthritis or gout. But then came the crucial part, the labs. So in the labs, the ANA was negative, and Rabi told us an amazing pearl that if ANA is negative, then we can be assured of the fact that SLE and SSC are extremely unlikely. And given the fact that anti-CCP is positive, which is very specific for rheumatoid arthritis, and given the fact that rheumatoid factor is also positive, so rheumatoid factor in isolation can be seen in cryoglobulinemias, infective endocarditis, even malignancies and chronic infections. But couple that with anti-CCP and symptomatic disease, then we are assured of the fact that it is indeed rheumatoid arthritis. And then the final piece of the puzzle, that what to make of the dyspnea, which Reza pointed us during the physical examination, what to make of it. And then if we combine all of this together, then chronic cough is classic for bronchiectasis. Dyspnea is not very common in bronchiectasis, but if we have ILD, if we have the alveolar involvement, and given the findings on pulmonary function tests, which are suggestive of restrictive lung defect, and imaging studies which shows the characteristic ground glass opacities, make us wonder, what if we are dealing with interstitial lung disease? And as Rabi told us, that ILDs in RA is so common, and RA can cause basically everything. It can cause UIP, it can cause NSIP, it can cause bronchiectasis, it can cause cryptogenic organizing pneumonia, so many things. So it was, perfect fit. We had nodules, we had vascular thing, we had the lung thing. So finally it was rheumatoid arthritis. And only one pearl that I wanted to share was that the nodules that we talked about, nodules can be seen in so many things. So usually they are subcutaneous nodules, but rheumatoid arthritis features nodules even sometimes in cardiac conduction system. So there have been cases of rheumatoid arthritis causing arrhythmias and conduction block. Then as Rabi mentioned, they can present in pleura itself. So they can cause pleural effusion also. So there are lots of ways in which nodules can present. So now I will always remember this case in which rheumatoid arthritis initially presented with ILD and not with the synovitis. So thank you so much for that teaching, Rafa, Reza, and Rabi. It was 3R. Rafa, Reza, Rabi. Amazing. Thank you so much for that.
Kirtan, I just want to say one thing. Like, look at your teaching, like the way you have it organized. It is extremely educational, from discussing clinical reasoning topics to teaching medical facts. It's just an amazing way to go through your brain on how you're thinking about this case, and very digestible. And I think it's a superb teaching, Kirtan. Thank you. We got to change your name to an R so we can say the 4 R's. Thank you all. Have a lovely day. Always a blast. Be blessed. Have a great weekend. Yeah, Kirtan. Right. All right. Take care.